Hey, everybody. Welcome to the Doctors and Dollars podcast. I'm your host, Nate Crannell. I am joined today by my guest, Dr. Ramin Rafie. Dr. Rafie is a graduate of UCLA and the University of California, Irvine School of Medicine. He is a father and a husband who has spent much of his career focused on home healthcare and proving, while being a top 1% ACO, that primary care in the home is a more cost-effective model of care. A native of Los Angeles, Dr. Rafie now resides in Michigan, where he splits his time between being a hospice director, a physician, and a strategic advisor in the home healthcare space. Welcome, Dr. Rafie. How are you?
Good morning. Good morning, Nate. Thank you very much. Thank you for the warm introduction. Happy to be here.
It's awesome. What's going well today for you?
It's going well. It's a beautiful day. The weather's unseasonably warm thanks to global warming here in Michigan. So I can't complain.
Unseasonably warm. Well, one thing I do know about you, you grew up in LA.
Yep.
So
Yep.
tell me, yeah, tell me a little bit about your journey as a kid growing up in LA and then moving into healthcare. And I was gonna say, being in the snowy winters of Michigan, but it
Right.
sounds like being in the unseasonably warm fall of Michigan. Tell me about that.
So my family immigrated to America in 1980, and I grew up in Los Angeles. Los Angeles is a major portal of immigrants into the country. And I grew up in a section of LA that is known for having a lot of people of my background, which is being Persian, which is Iranian, and particularly Jewish. And I went to high school, and I was fortunate enough to get into UCLA, which was my number one choice. And I enjoyed living in the 70 degrees weather year round. I used to sleep at night with the windows open, and I used to be curious as to why it was always so crowded there. And cost of living in LA was just crazy, and it just kept going higher. And one of my motivations for going to medical school, besides doing something I could enjoy doing, was so I could afford to live in California. So, like a lot of people, like three quarters of my classmates, I didn't get into medical school the first time I applied. I got on my second attempt, and I was fortunate I got into my number one choice at UC Irvine. And UC Irvine is just a true gem. I mean, I was very fortunate to go to medical school in what is called the American Riviera. Irvine is nestled in Orange County between Laguna Beach, Laguna Niguel. It's called the American Riviera because it's beautiful and once again 70 degrees weather year round. And I loved my time in medical school. For me, it was the first time I got to live on my own. I think most of my med school classmates had lived on their own during college. Some had not. Some of them, like me, mostly I think other immigrants had lived at home during college. And when they went to medical school, it was the first time they lived on their own. I did pretty well in medical school. I was elected to a lot of leadership positions. I was class president, and I got along with everybody in my class at my school. And I initially applied actually to get into anesthesia because it's it's a field where you don't have to open up your own office, and it affords a good lifestyle in the very expensive Southern California. And in my class of 92, actually 15 people went into anesthesia, which was a school record.
Oh, wow.
So this despite being class president and getting along with everybody, I did not get a residency in anesthesia in California. So that was a first blow to me. That was life doesn't go the way you plan it to be despite all your efforts. During my time in medical school, my dad, who had been a dentist, got diagnosed with Parkinson's, and he never really worked. He had struggled for about 10 years to get his license. My brother actually became a dentist first and helped my dad get his license. And he finally got his license after a 10-year struggle. And 2 years after he got his license, he got Parkinson's. So he never really worked.
Oh my
And I
gosh.
used that as my motivation for going into primary care because I really experienced firsthand how having an illness in the family affects other family members, the children. the financial situation of the family, um, and I just thought, who better than the son of a dentist that couldn't practice to become a doctor? So I basically went to the opposite end of the country. I did my internship in Massachusetts. I went to a small town called Pittsfield, and I went from a city of over 10 million people to a city of 10,000 people. And ironically enough, the residency program director was from Los Angeles. He had done his residency in Cedar Sinai and had worked there. And I think he tired of the hustle bustle of the big city and wanted to start a family, so he moved to Pittsfield, Massachusetts. Well, that was in 2003, and that was just when EMRs were starting to populate, and it was a very, very painful situation with the hospital EMR system. I remember we would get an admission. I would spend, 30 minutes to see the patient, and then it would literally take me over 2 hours or 3 hours to put the orders in the computer because the interface was so unfriendly.
For sure.
And the program went well. I did pretty well in the program, and they offered me a 3-year position, but I really felt I could have done better than that program. So I left that program, and I ended up getting a 2nd-year position later on in family medicine in Ohio. And that was in Columbus, Ohio, at a medical center called Grant, and it's a level 1 trauma center in Columbus, Ohio. So if the president ever gets shot while in Columbus, they don't go to OSU, they go to Grant Medical Center.
Nice.
And the hospital functioned very well. We were the only residents in this tremendous, ginormous hospital. So we were kind of like the ones that ran the whole place. And things ran a bit more smoothly. I remember one night while I was on call, I was doing an admission, and I had a patient who was being admitted with congestive heart failure. And during my internship in Massachusetts, I had learned to put these patients, the ones that were critically ill, on, like, let's say, a Lasix strip, which is a diuretic instead of giving it pill or IV, just a continuous IV drip. So it's a high level of treatment. I suggested that, I remember, one night to the attending I worked with, and the attending above me was double board certified in internal medicine and family medicine, and she had been attending for years. And she was not comfortable doing it. And I was comfortable doing it as a 2nd-year resident. And that's when it really became clear to me that as an adult learner, you got to know when you make your own decisions.
Mm-hmm.
And subsequently, I left that program. I had enough training. I got my Michigan license, and I started working for a company making house calls. Um, the company was actually a pretty small mom and pop company, and it grew larger and larger and larger. And we were still initially on paper charts, and then EMRs came out, which was kind of a rushed process and was a very much a botched process by the entire healthcare system. But anyways, the Medicare was interested in trying out different reimbursement models, and that's when ACOs came out, which are accountable care organizations. And the first year we did the ACO, we partnered up with a local hospital, and all the savings that we saved Medicare, the local hospital said, we're going to keep all the savings because we did the administrative work. So
Oh,
the
geez.
owner of, yeah, that's the politics of how a business works. So the owner of the ACO said, you know what, of the house call group said, you know what, we're going to make our own ACO. So we left the hospital, and the house call practice ended up becoming its own ACO. And we had offices in about 8 states, about 200 doctors. And basically, we kept what they don't explain to you in medical school or residency is that 8% of Medicare's population cost Medicare 80% of their budget. So the
Whoa, say
healthy,
that one more time.
yeah,
8%
so
of the people within
eight,
Medicare.
that's right, 8% of Medicare's population cost Medicare 80% of their budget. So the
Wow.
healthy 90% of the population that's in Medicare actually only eats up about 10% of Medicare's budget. So for Medicare to truly be viable, they got to treat that 8% in a lot more cost-effective way. And
Mm-hmm.
that's exactly what our house call practice did because we treated people in the home and we kept them out of the hospital. each day in the hospital is about $1,000 a day, whereas each visit in the home is about $100 a visit. So even if I was to make 2 or 3 visits and keep them out of the hospital, the $300 is far less than $1,000 for one day in the hospital. So basically, the ACO proved to Medicare that it's more cost effective to provide care in the home. And in great part, that's how the hospital at home model of care came to fruition. The guy who sold it in 2014 to an insurance company, very healthy non-figures. And in 2019, Medicare passed a waiver allowing all Medicare recipients to get a visiting doctor in the home. Before that, you had to be homebound. So the insurance company's business plan was to basically open up offices throughout the entire country, and they could basically service all Medicare patients because now basically everybody can get a visiting doctor. But as you know, in 2020, COVID came, and COVID really changed things up because we were owned by this large insurance entity. We were able to pivot seamlessly to doing telemedicine, and we did that for a couple, COVID going on. The insurance company didn't see the long-term plan. They knew that they were losing money every year, and they didn't want to keep on that track. So the insurance company actually divested from owning the house call company, and yet another private equity group came in and bought that house call company for pennies on the dollar. And that's kind of when I left the company, things getting further worse, and the leadership was changing. But what I did is during COVID is I got my MPA and I got certified in AI in medicine. And nationally, there's less than 1,000 physicians who are certified in AI in medicine. And I try to build on my experience in becoming an expert on the hospital at home model of care for companies out there that utilize that model of care. And one of the companies that utilize that are companies that provide remote patient monitoring, which is called RPM. So I advise a couple of RPM companies. I am back to doing clinical medicine, and I'm also a hospice director. I do that on the side as well. So I stay clinically active, but as time goes on, I'm trying to build up my own consulting business as becoming more of a consultant in this niche of the hospital at home and utilizing my education in AI in medicine. So that's where I'm at today.
It's awesome. Where do you see I mean, I have a bunch of questions, so thank you for sharing all that, because that was a great peek into a look into your journey, I guess you could say. So I have a bunch of questions that kind of came up as you were talking there, but I want to stick on the most recent topic, and then I want to kind of work back with you. But
Sure.
you mentioned being a strategic advisor. That can mean a lot of things, right? Depending on the industry that you're in. You've held that title at several companies, right? Even including those in healthcare, and those even with artificial intelligence. Like, where do you see,
Right.
or how do you see AI becoming a key tool to be used by physicians in healthcare?
I will never replace physicians. It's a
Mhm.
misnomer. It's misinformation out there. Some physicians think that AI will replace physicians. That will never happen. AI will ultimately augment what a physician's job is, make their workflow smoother and easier, and hopefully improve their workflow. The there's every aspect of healthcare can be affected by AI, from billing to revenue cycle management to hospital procurement, hospital sources management, billing. But the fields of medicine that are going to be affected the most are going to be the fields that are image oriented. So
Mm,
radiology, pathology. These fields are being affected today, and not for the worse, but for the better, because AI engines are being taught to view all these films. And when a radiologist comes in the morning, they have, let's say, 1,000 films to view. Well, if the AI engine has already viewed them overnight, they're going to point out the ones that are concerning to them to the top of the queue in the morning. So those are going to get first viewed. And ultimately, it's going to be read by a radiologist. And there are many times, ultimately, people are people and people make mistakes that the AI will make up and pick up um, points on an imaging file that a radiologist may miss. In pathology, it's being done. There's a national shortage of pathologists, and it takes over 10 years for somebody to become a pathologist. A patient is in the operating room, and the surgeon takes a tissue sample. Usually, they would send it off to the pathologist. They'd have to wait 2 hours to get the results back to see if they have clear margins. Today, there is a machine that goes in the operating room, and I believe Mount Sinai and a couple other health systems have it, where you put the tissue in the machine, and in less than 5 minutes, the machine tells them if they have clear margins or not. So the machine
Unbelievable.
is doing the job of the pathologist. So it's just expediting the process. And I really don't think it's eliminating anybody's job. It's just augmenting a physician's job. What it has done is it's created actually a lot of new roles. Now all healthcare systems have CMIOs, which is a chief medical informatics officer. Some have a chief AI officer because AI ultimately has to be tailored to each hospital, has to be tailored to each department in the hospital. So you can't have a one size fits all solution. So each hospital has to develop its own AI solutions. And right now, Mayo Clinic has partnered with Google. They're doing tremendous work. I believe Duke University Medical Center has partnered with Microsoft Azure, and they're doing partnerships where they're trying to implement AI software to make things more smoothly. And ultimately, these are going to be um, the examples that are going to lead the way for the whole country.
That's crazy. Well, and there it sounds like there's positive impacts and kind of negative impacts depending on what type of physician you are. You had mentioned wanting to be an anesthesiologist, couldn't do that. You mentioned a pathologist has 10 extra years, it sounds like, to get into that route. But not long into your attending career, you became a medical director at a hospice center. What do you think
Right.
pulled you into the world of helping those that are near the end of their days?
So when I was making house calls, a lot of the patients that we see were chronically ill,
Hmm.
and I would very openly talk about families about what their long-term goals were, what their end-stage goals are, and talk about death very openly. And very few physicians would do that. Very few physicians are comfortable to do that. We get no training for that in medical school, no training for that in residency. So it's kind of like you got to take it on yourself to do things like many things in life. And the medical director of the house call company saw that I was consistently taking the lead and having these conversations. So she promoted me to being a hospice director in the house call company. And the house call company, like I said, had offices in 8 states. They had about 20 offices. And out of 20 offices, my office was the best performing one in the whole country. So they actually gave me a second office. I was the medical director of also the one in Ann Arbor, as well as the one in Metro Detroit. And I was able to have my census appropriate. You know, you get dinged if you have people on hospice too long by Medicare. And we were able to predict people's mortality very accurately. And it just kept growing. I ended up as a medical director of a hospice, you're a team leader. And given my experience as a class president and my other leadership positions, it was a very natural position for me to take and lead the team. I enjoyed it. It was a very um, multi um, different services. Like there was nurses, chaplains, social workers on there, and it was a diverse panel of people that I would lead. And even though I was a leader, I kept it like as a flat level where I felt I invited everybody to talk, and I created a space of comfort and safe space. And I think it allowed the nurses to perform very well, and that's one of the reasons that the teams I led did very well because the team workers ultimately felt it was a safe space, and that's something that's very important in the culture of any organization. A leader has to create a safe space where the workers can ask questions, They can question authority. They can question how things are done and why things are done the way they are. When I went through medical school and residency, that really was frowned upon. If you ask questions, the answer was, "This is just the way we always do it. That's just the way it is." And it's just not going to continue to fly going forward in 2023. There's a shortage of physicians. A lot of U.S. graduates that come out don't want to do a residency because of the moral injury, and it's just a very toxic environment. And if the U.S. is truly going to build a stronger work population, they have to be compassionate to their healthcare workers, not just the doctors, but the nurses as well.
Yeah, I mean, leadership in any type of industry is super important. And it sounds like you've progressed a movement within the leadership within healthcare of you got to be able to be open and allow others to talk and be able to be adaptive. And a lot of times you'll see great companies who have a great product, but they have poor leadership, just fail.
That's right.
Right. And
That's
unfortunately
right.
it's not everyone will be like, oh, what happened to that one thing? It's like, they went out of business. Like, what? Oh, I love that product. It was awesome. Well, leadership, kind of took them down the drain. So I commend you
Yeah, that's
for
right.
focusing not only on, patients in the hospice space or patients in any hospital that you're working in, but also being focused on the leadership and the staff that's there and making sure that they're having a great experience, because that's honestly part of where some of the success of those places come from. Hey everyone, I wanted to take a moment to talk about what I do outside of being the host of the Doctors and Dollars podcast. I'm the CFO of Grand Vision Capital Group. At Grand Vision, we work with high income earners who make a great living, but still can't quite break through that true wealth ceiling. We utilize strategically chosen investments tailored for high income earners. The question always at the forefront of our minds is, why wait for retirement to finally live when you can implement an investment strategy that will impact your life today? To be honest, most of the people we work with never even knew these options existed because their financial planner doesn't have access to these exclusive investments. So, if you're ready to finally turn your high income into real wealth, visit our website, www.grandvision.co, and hit the Take Action button in the top right corner to schedule some time with me. Or even better, connect, follow me on any of my social media accounts, shoot me a message. Now, back to the show.
That's right. Thank you.
Yeah, one thing you mentioned, and I think it kind of caught me off guard. You said that Medicare dings the facility for having someone in hospice too long. Did I hear that correctly?
So every time a physician certifies a patient for hospice, the physician is saying, "I think this patient is in their last 6 months of life."
Mm-hmm.
So the truth is, nobody can predict mortality. But if you're still on hospice 2 years later, that means 4 times the physician has said, "I think this patient's in the last 6 months of life." And 2 years later, that's a big red flag that this patient is still alive. So
Mm-hmm.
even if patients are on hospice after 6 months, it creates flags. So every hospice has some people that are on hospice for over 6 months, but if you have too many people that are on for over a year or 2 years, you become an outlier and you become a target for an audit by Medicare, and ultimately you want to try to avoid that.
Gotcha. Yeah, one of the big questions I wanted to talk to you about today was around long-term care, and I guess in my view, I've had grandparents and great grandparents and things like that have gone to a nursing home. My grandma had dementia before she passed. So going through some of those things, that may be a little bit different than hospice. But when you think of long-term care and the costs that come with that, long-term care costs continue to rise at 5 to 8% per year. With
Yep.
home care now being home care is the fastest growing segment in the long-term care system. How do you feel like families should prepare for this financially when healthcare is creating a greater longevity for people? But then to go back to your point, if you're in there too long, you don't want to raise red flags and all of a sudden clinics and centers are being dinged for it. Healthcare in general is creating more longevity, right? And so
Right.
people are going
That's
to
right.
be they're going to be living longer, which is great. But eventually their body deteriorates. They need, some additional care. You know, how do you feel like families should prepare financially, when healthcare is creating this longevity and people are needing more long-term care?
Well, they're supposed to save up their whole life for a nest egg and a retirement. And there is such a thing nowadays that you can help buy long-term care insurance when you're in your 50s. You can buy long-term care insurance, and that would help pay for assisted living or for providing an aid in the home. And I encourage people to look into that. I think nowadays with people easily living longer, that's very much needed. But the truth is, actually, some of the companies that provided that service have gone bankrupt because
Hmm.
uh, it's not becoming profitable for them as a business. So it's harder and harder to get those kinds of policies. Um, I know myself. I've been a physician for 15 years. I've had about a dozen or so patients that have lived over 100.
Wow.
And when you think about it, these people have been collecting Social Security since they were 65. So they're collecting for over 50 years. And well, over 40 years, sometimes over 50. But the vast majority of those people did not work for 50 years. So they did not contribute into the system for 50 years. So the system is financially unviable, not viable. And that became very apparent to me when I did my internship in Massachusetts, when I recognized that, half the people in the hospital were people on disability that never worked, and basically our tax dollars are paying for them. And
Hmm.
you realize very quickly that a quarter of the population is always in school, a quarter of the population is probably retiring. So half of the population that is working is basically providing the entire tax base for the entire country.
Hmm.
And right now there's a called silver tsunami. There's 10,000 people a day turning 65. And that's why there's a tremendous crunch in the healthcare system to provide healthcare for the elderly people, because there's such a need for it. But the the workforce is actually really not there. And there's a big push of these elderly people as they get into retirement. A lot of them get on these Medicare Advantage plans. And in the country, I believe there's 4 or 5 Medicare Advantage plans. These Medicare Advantage plans are owned by insurance companies, and they've all created their own verticals where they provide their own hospital, sometimes their own physician groups, and they try to just keep the patients in their own verticals. And the Medicare Advantage plans seem to be more attractive to people because it's more cost effective than, say, maybe traditional Medicare. But what you don't realize is you end up being trapped into this narrow vertical. And when you get ill, your options are going to be very limited as to what services you get, because you're trapped in this Medicare Advantage vertical. And a lot of the physicians that I've talked to, some who actually even sell insurance nowadays, um, they don't recommend people sign up for the Medicare Advantage. And there's a lot of articles, and it's been documented that all 5 of these Medicare Advantage insurance companies have overbilled the Medicare system and have taken advantage of having these Medicare Advantage plans. And it's gotten to the point where the ultimate bully in the room is the government. And it's only the government that has enough weight to tackle these ginormous medical insurance entities, because the physicians don't have the power. And physicians, the way the system is designed, we're too splintered to get together to do anything. So ultimately, the government has to get together and address this issue of Medicare Advantage. But I don't think it's ever going to get done because it's not a popular topic politically. You never hear about these politicians who are running for president talking about the details of the Medicare Advantage or Medicare plan. They just talk about the healthcare system, but they don't they don't they don't hone in on the dysfunction of the healthcare system and how the insurance companies have siphoned up so much of the resources. And physicians' income is only 7% of the U.S. healthcare economy. So the physicians do not take a lot of the money in the healthcare system. They're actually a very,
Hmm.
very small percentage. And the way the healthcare system is going, right now, I think around 70% of doctors would not recommend it to their children or other people. And going forward, it's going to be a shortage. It's going to be a big problem.
Yeah, and that's just unfortunate to hear that's it's breeding that type of that thought process, right? I feel like back in the day, and I say that, like the 40s and the 50s, if you were a physician and your kids were, smart and adept and they worked hard, you would tell them, hey, you should become a doctor as well. And then that there's probably thousands of stories out there of, multi-generational doctors. And
Right.
because of the healthcare system now, and you really hit on it, the Medicare system, the health insurance system, making it harder for physicians to really do the one-on-one care, that it was designed to do. It makes it really tough. And so I wanted to ask you the Medicare question just because I know a little bit about it. Obviously being a former financial advisor, long-term care was something that I sold. So very familiar with how that all works. But hearing it from a physician on the Medicare side of things and the challenges that you guys face was really eye-opening for me because, when I was a financial advisor, I always told people, hey, don't rely on, Medicare, don't rely on what the government's willing to pay for you because they're not going to stick you in a nice place, right? You said it with
That's right.
those five pillars. um, whatever they're willing to pay for, they might stick you in a facility with white walls and you're going to have a neighbor in the bed right next to you. It's not going to be like the fancy places that you see on TV. And so I always told my clients, don't rely on that to be your source of payment, right? When it comes to that type of care, you got to create those things on your own. And so really, I always narrowed it down to three ways, right? There was number one, create passive or guaranteed income sources that can carry that cost through the duration of their retirement and through the duration of their lives. Number two, well, you said it, leverage long-term care insurance that a lot of times has inflation growth option built into it that's going to go up as the cost of care and the cost of inflation rises. You have that type of policy built in. And even now today, and this probably wasn't something, I don't think, that was available even, let's say, 20 years ago when you were really diving into things in 2003, was there are some types of life insurance policies, that allow you to borrow against the policy or withdraw benefits early, in certain cases to help pay for long-term care. And then you can use that remaining balance, that gets paid out when you pass away. But being able to have those three sources, guaranteed income sources like a social security, or you've created passive wealth, throughout your life, long-term care, and some types of life insurance. I think if you can, create those on your own and be able to pay for care that you need, because, what's the statistic these days? Like 72% of people are going to need some level of long-term care at some point in their lives. Uh, because it's not like 100 years ago where you kind of went down the path and got near the end of your life, and then your kids and your grandkids would just take care of you, right?
Right.
And that's just not the case anymore. And you've seen that more than anyone, especially seeing centenarians. That's pretty cool that you've seen that many. But um, to know that life is lasting much longer, and
Right.
financially you have to be prepared for it. You can't just kind of go on a whim and go in blindly to something like that, knowing that, I mean, 3 out of 4 chance that you're going to end up needing care, and you got to be prepared for that financially. So I'm grateful that you were able to tell the one side of it that I didn't know about, because obviously I always told clients, prepare for it yourself, because you've seen the people who have not, right? And you've seen the people who have just relied on the Medicare system, and they get put into a pillar or a column that maybe wasn't in their best interest, or
Right.
wasn't what they were expecting, for their final 6 months of life. And so you've opened my eyes a little bit to that, and so I appreciate that.
I wanted to just make a couple other points I wanted to mention, if you don't mind.
Yeah, go ahead.
Everybody's always heard of the golden rule. The golden rule is to treat others as the way you want to be treated. The golden rule in medicine is he who holds the gold makes the rule. And that
Mm,
basically is basically all the rules in healthcare are made by Medicare and the insurance companies, because ultimately they are the payers. If physicians are brave and smart enough to be able to get out of the insurance-based system, and that's what the DPC movement is, the direct primary care, the physicians that move out of the insurance-based system, and they do a cash-based practice, they're able to actually thrive a lot better. But So long as you're in the insurance-based system, you have to play all these games that the insurance companies, including the government, ultimately put you through. One of the physicians I worked with in Michigan, he was actually a pharmacist before he became a physician. While he was a physician, he decided to open up an urgent care. And I remember he showed me his reimbursement. He had seen a patient, he had spent 25 minutes. It was a moderate complexity visit, and the patient was on Medicaid, and state Medicaid reimbursed them all of 25 cents for that 20-minute visit.
Wow.
The, the stamp on the envelope was more than the reimbursement for the visit. And that was just scary to me. Imagine you spend 25 minutes, you've spent all this money in building a facility, and your reimbursement is 25 cents. You can work an 8-hour day and maybe be able to afford a Happy Meal for your kid. That was 8 years ago. Today you couldn't even afford a Happy Meal for your kid. So it's a very dysfunctional system. Nobody can function on 25 cents of reimbursement for 25 minutes of time. I mean, your overhead on your electricity and your thing is going to be more than that. So this is something physicians unfortunately need to be aware of, and nowhere do they educate you on this. Unfortunately, you kind of have to learn things the hard way yourself.
For sure. We had a guest here on the show a little while back that has gotten more into that cash-based system, just got tired of the health insurance industry. What he does in regenerative medicine is a little bit, it's obviously more cost effective than a let's say a full orthopedic surgery. What types of industry, or I don't want to call them industries, but what types of care or fields within medicine do you think really can't do cash based, just simply because the cost is so high that everyone, you have to rely on your insurance? People, this type of physician.
Well, I mean, ultimately, I mean, you're going to be hard pressed finding a neurosurgeon that's out of the insurance-based system because
Mhm.
there's such a shortage of neurosurgeons. They're pretty much are employees of these health systems. Um, I mean, myself, I had a hysterectomy, and this was a 20-minute procedure in the hospital. And for that 20-minute procedure, my bill was $48,000. I mean, it's
Wow.
crazy. And the insurance reimbursed 46,000, so the remaining 2,000 was my responsibility. But this was a 20-minute procedure. This was something that I know the surgeon can do in their sleep. And ultimately, of that $48,000 bill, I'm sure the physician himself didn't get even $1,000.
Yeah.
All that money just went to the hospital, and it's just the hospitals are like mafias, and it's a very uneven system, and the hospitals get reimbursed at a higher rate than if a physician was to open up their own office, which makes it very difficult. Like I was explaining to you, the physician that tried to open up an urgent care, you can't make things work on 25 cents for 25 minutes.
No.
So it's the system is designed to make it very difficult, if not impossible, for a physician to survive. If to survive is you got to do a cash-based practice, but you can't do that in certain specialties. So I mean, you're never going to see a pathologist for cash. You're never going to see a radiologist for cash or an anesthesiologist. So those specialists are hospital-based, and they're trapped in the system. As a primary care physician, um, I could open up my own cash-based practice, and I live in a nice pocket of Detroit, and I've even asked online how many people would be willing to pay cash for a practice, and I had a very small um, interest gauge in that. Most
Mhm.
people want their insurance to pay for it, so it's a very difficult niche to break into.
Do you think that's been bred from the health insurance companies just gaining more power? Right. Think of,
It
the
is.
1950s. It was probably, health insurance was still around back then, I presume, but like I feel like there's probably a lot more cash-based um fields within healthcare now, because health insurance has become so powerful, because they've created that golden rule that you just talked about. Doctors don't really have a choice. And so the environment around them has just for a hysterectomy to cost $48,000 and 46 is covered by insurance. Like, I mean, they have 90% of the power there. Where,
Yeah.
Let's say 50 years ago, a hysterectomy might have only cost that $2,000 difference
Right.
total. And so somebody maybe could have saved up and paid cash and not had to rely on their health insurance and, file the claim and, potentially increase rate. I just feel like that's, um, the more and more physicians I talk to, the more I realize that the health insurance industry has now overtaken the healthcare industry, if that makes sense.
Oh, for sure. It's they're the 800-pound gorilla, and the only person that can take them down, like I said, is the government. But the government's not going to touch it because it's not popular. Even though
Mhm.
everybody, probably more Americans can get united on that one issue than any other issue out there. The government's not going to touch it because it's not popular. Um, they're private companies, and this is America. It's all about capitalism.
Absolutely. Well, Dr. Rafie, I appreciate you taking some time. I know you were heading into work, and I want to let you get back to it. But this has been enlightening. This has been a great conversation. I appreciate all that you shared. Uh, Anything before you go that you want to throw out there that you want to drive home and is most important to you?
Thank you, Nate. I appreciate the opportunity to talk. I appreciate you giving me an opportunity to get on a soapbox. I think ultimately, um, more physicians unfortunately got to take charge of their own careers, and I think to be successful, you got to create a niche for yourself outside of this insurance-based system. Um, but I hope the public is more aware of the insurance monopolies that's going on, or oligopolies. And I hope that this is an issue that is brought up politically, whether you're a Democrat or a Republican. It's a major issue. It's the reason why healthcare is a tapeworm of the U.S. economy. It has nothing to do with the doctors. It has nothing to do with the nurses. It has to do with the insurance companies. And if the U.S. has any chance of keeping the healthcare costs at bay, they need to tackle these insurance companies and the oligopolies that they've created. Whether or not that happens, who knows? I would not hold my breath, but that's the big issue.
Awesome. Well, again, appreciate you sharing all that you did today. This was awesome. Wishing you all the best. You're going to continue to grow. You're going to continue to lead. I'm excited to see where you end up.
Thank you, Nate. Have a good day. I appreciate the chance.
Yep. See ya.
Bye bye.
Hey, everyone. As we wrap up today's episode, I want to talk about the second opinion. As most of our listeners are physicians, you guys know the importance of having another medical professional's insight for a patient's treatment plan. But have you ever considered having a second opinion on your financial plan? Or have you simply trusted your financial advisor that they've already leveraged every strategy that your family needs to be 100% on track to meet your financial goals? That's why, for my Doctors and Dollars listeners, each Wednesday I block off 3 time slots, an hour each, to provide a free second opinion of their financial plan. During this hour, we'll reevaluate your financial goals and your risk tolerance. We'll ensure tax mitigation strategies are in place and ultimately give you confidence with your financial outlook, because that is what drives a happy home, a happy marriage, and peace of mind. These 3 spots each Wednesday do fill up fast. Send me an email at nate@grandvision.co or head over to www.grandvision.co/second opinion to fill out a quick form about you and schedule a time for us to meet. Thanks for tuning in, and I hope the rest of your week is abundant. Cheers.